some of the reasons why there's this huge level of overtreatment, and also some strategies that have been implemented to try and resolve this problem.
So we're going to start with a graph which is similar to the one you saw earlier, which shows total healthcare expenditures on the bottom versus life expectancy of developed countries on the vertical axis. As you can see, the United States is a huge outlier. The United States spends about $7,000 per capita on its healthcare versus a country like Sweden, which spends only $3,000. But the United States is ranked 44th in the world for infant mortality, where a country like Sweden, which is renowned for its healthcare, is much below the United States. And we think that unnecessary treatments is a big reason for that and highlights the inefficiency of our healthcare system.
So this brings us to the battle over the soul of American medicine. I'm sure many of you, as we have been following the political debate over healthcare reform over the past year. However, there's an equally big, possibly more important battle going on behind the scenes over the soul of American medicine and the core ideals of our healthcare system. Right now, our core values of our healthcare system are based more on volume rather than quality, which is what is driving up our healthcare costs, as you can see in this graph. And as you can see from the light blue bars, these costs are only going to rise unless we can shift those values. So what's driving up these costs? One of the first factors is administrative costs, which some estimates say account for about 1/3 of our overall healthcare spending. The second is price insensitivity of patients, which basically is that patients who are insured will spend more healthcare dollars even though they're spending less out of pocket. As you can see from the graph, the red line, as public funds increase, out-of-pocket payments will decrease. So basically people are paying less of their own money and using more of the government's. And then finally, defensive medicine, which is that doctors will will do more procedures and more unnecessary tests and stuff to avoid being sued for malpractice later on, which Graham's going to discuss.
So defensive medicine is when doctors and hospitals perform extra tests and procedures to make sure they're not sued in the future for having never done them in the first place. Now, 2008, Massachusetts Medical Society study found that 83% of its doctors practice defensive medicine at a cost of approximately $1.4 billion a year. That's a huge amount of waste and unnecessary treatments that are done purely to make sure that doctors are not sued, not to increase the outcome for the patient. So this, again, just highlights the inefficiency of our healthcare system and adds to the cost.
So this brings us to the overall problem that we're going to discuss today of unnecessary care. Some estimates say that this accounts for about 1/5 to 1/3 of our overall healthcare dollars, which is $500 to $700 billion wasted per year. And also, not only does that add on to the already monumental healthcare costs of our healthcare system, but it also may be causing more harm than good by subjecting people to care that they don't actually need. And so it's an estimated 30,000 Americans a year are being killed by this unnecessary medical treatment, which is the equivalent of a sold-out game at Fenway Park, everybody there dying every year because of unnecessary medical treatment. So it's a huge problem.
This is Dr. Atul Gawande. He's a surgeon in Brigham Women's Hospital in Boston, and he's also a professor at Harvard University School for Public Health. And he did a study which he entitled The Cost Conundrum, where he analyzed Medicare spending in 2 towns in Texas. One is McAllen, Texas, on the border of Mexico, and one is El Paso. Both towns are very similar in demographics and have very similar healthcare systems, but he found very interesting variations in Medicare spending. As you can see in the top statistics, the median incomes are about the same, the poverty rates between the 2 towns are approximately the same, and the unemployment rates are about the same. And when we continue to the healthcare statistics, you can see deaths from cardiovascular disease are almost the same, with El Paso County even being a little bit better. You have infant death mortality rate being about the same, and physician supplies being about the same, with El Paso County again being about a little bit better than Hidalgo County, which has McAllen. What Dr. Gawande found was that whereas El Paso County spends only about $7,500 per Medicare recipient, which is about the national average, McAllen spends almost twice that, at $13,700 per Medicare recipient. And he investigated that and tried to understand why McAllen is able to spend so much more and have the same, if not worse, healthcare statistics than its neighboring border town of El Paso. He found that between 2001 and 2005, Medicare recipients in McAllen were 50% more likely to see a specialist, and also they were 2/3 more likely to see 10 or more specialists within a 6-month period. In addition, they were 2 to 3 more times likely to have a pacemaker or to receive cardiovascular bypass surgery, which had no effect on reducing cardiovascular disease as can be seen by this statistic between the 2 towns. In addition, Medicare in McAllen pays for 5 times as many in-home nurse visits than it did in El Paso. So this just again highlights how much extra fat there is, how much unnecessary spending there is in some towns, which doesn't increase the outcome for the patient, but just increases revenue for hospitals or increases
So in 1996, Dr. John Weinberger, who works at the Dartmouth School of Public Health, did essentially the same study, but instead he did it on a national scale. So what he did is he divided up the country into 306 hospital referral regions, and he basically found the same amount of variations in medical spending. For instance, in Miami, medical spending per capita was about $8,000, while in Minneapolis it was only $3,000. So he found that some regions were subjecting their patients to a huge level of unnecessary care, because these variations couldn't be contributed to levels such as differing levels of illness, since they're pretty much the same around the country, and it also couldn't be attributed to healthcare costs because they're controlled by the government. So you can see the extreme amount of variation in all of these dots. One of these dots is, or each of these dots is a hospital referral region in the country, and the 4 red dots are 4 different towns in California. And so you can see down at the bottom, San Francisco is performing about 4 coronary artery bypass graft surgeries per 1,000 Medicare enrollees, while in Reading they're performing 11 per 1,000. And it's also important to note that in Reading in 2002, which is actually after this graph was done, 2 doctors at the Reading Medical Center were indicted for $15 million of Medicare fraud for performing unnecessary heart surgeries. So that can sometimes be a factor in exploring these variations.
Okay. So you might be wondering, what's wrong with doing more tests or more procedures? You might be thinking that it might help your chance of being a better outcome for the procedure. The fact is, the more procedures you do, the higher chance of an adverse event taking place during the procedure. And as a matter of fact, a study's been done that's shown between 44,000 and 98,000 Americans die each year as a result of adverse events from unnecessary treatment. That's greater than the 8th leading cause of death, which right now is auto accidents in the United States. It's also greater than all the people who died from breast cancer, Americans in the United States, and also it's almost 3 times greater than the amount of people who died from AIDS in the United States. So unnecessary treatments have a real consequence for people in the United States, and it's something that needs to be taken very seriously. And so we have, to resolve this problem, we think there are 4 important models in the United States out there right now. There's coordinated care, which Maddie's going to talk about with the Mayo Clinic. There's the Vickwood model in West Virginia. There's Intermountain Healthcare, which is a healthcare system in Utah. And there's pay-for-performance, which emphasizes shifting from quantity to quality.
So coordination of care can really be exemplified by the Mayo Clinic, which is based in Rochester, Minnesota. And the one thing that makes it really different from a lot of healthcare systems around the country is that it's practicing patient-first medicine, no matter what the cost is to the hospital. Also, doctors are salaried so that they don't have any incentive to perform any extraneous tests or procedures in order to supplement their income. Probably the biggest thing that they do is they practice cooperative science, which is essentially any patient in the hospital has a team of doctors who are coordinating with each other. So this promotes not only coordination of care, but it also prevents any miscommunications that could result in medical errors in the future. And also it's important to note that Medicare spending there is in the lowest 15% of the country, whereas the people who live there are getting a really high quality of care because the Mayo Clinic is the largest healthcare provider in town.
Okay. Then there's the Dr. Vickwood model. Dr. Vickwood in West Virginia faces the problem of a lot of West Virginians who can't afford health care. And so to fix that problem, he has created a model where individuals can pay $83 a month per individual or $125 per family, and they get unlimited primary and urgent care. And what this does is it removes that incentive for physicians to do extra procedures to increase revenue. Because he can do 2 procedures for a patient or he can do 15. He can be paid $83 or $125. So again, it shifts the emphasis off of quantity and back to quality. And it extends coverage to people who really can't afford the healthcare plans that are beyond their price ability. And most people can usually afford $83 per entire month.
So Intermountain, as Graham said, is a hospital system that's based in Utah. And what makes Intermountain really unique is that it's a nonprofit hospital, and also its board of directors is comprised solely of volunteers. So this means that the board of directors isn't concerned with the hospital profit margin or anything like that, but it's more concerned with the outcomes of the patient. Also, what they've done is they've computerized their medical records, which cuts out on a huge chunk of administrative costs, which we already talked about, account for about 1/3 of all of our healthcare costs in the nation. And finally, the most important thing that they do is they use scientific evidence to back up everything that they do in the hospital. For instance, in 2001, a doctor found that babies born before 39 weeks had really high rates of ventilator use and respiratory distress. And so they stopped performing early elective deliveries, and this not only allowed for the newborns to have better outcomes, but it also made the costs really significantly lower to the patients. And as you can see, Utah has the lowest Medicare spending in the nation.
Okay. Another model is pay for performance, which is similar to Dr. Vickwood's model. It also shifts that emphasis away from quantity and back to quality. Also similar to his model, doctors are paid and hospitals are not paid for procedure, but they're paid for the quality of the outcome of the patient. So again, they can do 2 procedures or they can do 10 for each patient, but they're paid based on how the outcome for the patient is. So there's a couple criticisms of this model. The first one is that it's hard to qualitatively measure how patients do when it comes to compensating doctors and hospitals for their time and the expensive procedures they do. Also, if a hospital sends a patient home with a certain regimen for recovery and they don't comply with that, it's difficult to, again, compensate a doctor for the time they spent trying to help that patient. But also, a big theme of our presentation is we think coordinated care is important, for doctors to work together to try to create the best outcome for the patient. This doesn't really incentivize that, as doctors will sometimes try to get the greater reward for their own time spent. But overall, coordinated care and paying for the overall outcome of the patient is an important model for our healthcare system.
So what does the current healthcare bill do to address this problem? Unfortunately, it's more concerned with expanding insurance coverage, which might actually add on to the costs, because as I talked about, people are paying less out of pocket and more of the government's money. But some things that they do is that there is going to be a tax on expensive Cadillac insurance plans, which will hopefully bring costs down. And then also there's going to be a pilot Medicare program that will allow doctors to share whatever money they spend as long as they're offering better outcomes to their patients. And then finally, the Patient-Centered Health Research Group is going to have a $600 million budget, and that should allow that treatment will be not only necessary but also effective, and there will be clinical trials done to prove that.
As we saw in the cost conundrum study that Dr. Gawande did, it is very possible for a low-cost area to spend less money and have better health outcomes without spending a lot of money like the high and medium-cost areas such as McAllen. And as Peter Orzag, the President's Budget Director, noted, it's very possible to do this without compromising the health quality outcomes for the patient. And right now we have a problem in America where we're trying to bring more health coverage to more people without compromising that quality. And until we control costs, it's not going to be possible. But fortunately, we've shown that we think there's a lot of fat and excess inefficiency which we can reduce. And so there's a lot of hope to move forward and bring more coverage to more people without compromising the quality. Thank you.
You all like to stand up for 1 minute? We're going to swap laptops so you can just get a breather and you can just stretch your arms a little bit.
Okay, let's go ahead and we have our final 2 presentations. They are, like the previous ones, fantastic. They bring us back to one of the most basic elements of public health, and that has to do with water. 80% of communicable diseases are transmitted by tainted water. Back in 2003, when we had the hurricane come through here and knocked out power, our power came back on eventually, but what we actually did, I think the first time ever, Steve, you don't remember this because you weren't here, we evacuated the university, sent all the kids back home, which was no small thing. And it wasn't because of the power. We could have done candles and stuff. But we were concerned that the sanitation wouldn't work, and that could lead to an outbreak of a communicable disease. So it brought home to a lot of students how important water is. Steve Richards and Rob Dow are going to focus their talk on water internationally and then also domestically. And then Chad Krieger and Jack Wisniewski are going to bring it back to a domestic focus with water in the United States. Thank you.
People are depending on water in the street. Some of them are coming as far as 30 kilometers away.
understand how that's possible, I guess. This is the water that about 4,000 people here drink every single day.
You get water from this river. Yeah. If you check within the community, you get, I think, about 60% of the community are sick, are suffering from the central waterborne diseases.
When's the last time you've been sick?
Me, even right now, I'm sick.
This water here is the only water this hospital has. They use it for the laundry, which is where we are now, to wash the white sheets, and they give it to the patients for drinking. Doctor, help me. Explain to me how the water for the hospital works. You pump the water from the river up to the hospital.
Hey guys, my name is Steve, and this is Rob, and we're going to talk to you today about water. In the global health community, you hear about the big names, the TB, malaria, HIV, AIDS. We can tend to overlook water. Rob and I have both trained to become EMTs. In our training, we learn to address the airway first, and then the breathing, and then circulation. It doesn't matter if the blood's pumping if the patient isn't getting oxygen. That's how we should view water. It doesn't matter how many vitamins, how many medications we have. If that patient is drinking unsanitized, dirty water, they're going to be sick and they will die. And we can guarantee that.
All right, so this is Tabia. She's 14 years old, and she lives in Malawi, which is located on the eastern coast of southern Africa. And this is her younger sister, Carolina, who's 12 years old. And every day they have to wake up at 5 in the morning, and they need to walk about 20 minutes down a steep hill, making sure to avoid all the rocks because there's a lot of rocks in the hill. And they need to get water from this watering hole. And this watering hole is nothing really that special. It's just a hole dug in the ground. And they need to fill up their 5-gallon jugs, and they need to carry them back up. But the water, although it looks deceivingly clear, is only that way because it hasn't rained recently. And when the rains come, it washes bacteria, it washes feces, it washes sticks, dirt, everything that you wouldn't really want to drink. Now, when they bring the water back up, they need to use it for their drinking, they need to use it for their washing themselves, and they only have 5 gallons. But afterwards, they have to go to school, and they need to do it again. And they need to get enough water with all their friends for the school for the entire day. Now, these girls use about 5 gallons of water. The average American uses about 80 gallons of water a day. Now, in order to get this much water, you'd have to go to Ucrops, which is about a mile away, and you have to walk there. And you'd have to carry a 40-pound, 5-gallon jug of water, balance it on your head, and you need to do that 16 times to get enough water to drink for the entire day and to wash yourself in the shower with. And I mean, I could never imagine doing that, and I don't know how they do it at least once a day. So it's definitely a major issue.
At the turn of the millennium, we made a promise to address some of the world's biggest issues. And we're doing well, but we're not on track at all. Water isn't even one of the main topics. It's a subcategory. That kind of gives insight into where we're going wrong, why we're not on track to reach having the number of people without drinking water by the year 2015.
All right, so the problem is water is definitely stressed. It's definitely become a commodity, and privatized companies are taking advantage of that. There's only 2.5% of fresh water on Earth, and there's only 0.5 fresh water that we can actually access. Most of the rest of it is all locked in ice caps and glaciers and everything. We just can't get to it. And all these companies are kind of taking advantage of that, and they're trying to capitalize and make a profit off a lot of the water. And they're selling it back to the communities, but the communities do not have enough money to buy the water back from the companies. So they're still forced to drink the dirty water. Now, a lot of this dirty water is coming from like rivers and streams that these privatized companies are taking the water from. So they're actually dumping the filth that they filter out back into those same streams. So the water is net dirtier. There's even more bacteria. So people are getting just sicker and sicker because the privatized companies aren't just helping out at all.
There's no foolproof solution to the water crisis. Every village is different. Every village needs its own innovative strategy. We're going to kind of go over a few of the ways that we think individual communities can address the issue. Larger communities, perhaps with a stream nearby that they can direct near the village, can use what we call UV filtration. Uses UV light to kill a lot of the bacteria and viruses that are going to make people sick. And this also requires an operator year-round, and he's going to get paid 14 cents a year per person. That's going to stimulate the economy. Play pumps are an exciting innovation in the water community that everyone's pretty excited about. It is a merry-go-round. It's a well that pumps water into a big container, pretty much, and it's powered by kids' energy. And that's an energy that I don't think we're going to run out of anytime soon. The container also has 4 sides, each with an advertising platform. This pretty much pays for itself. There's another new innovation, a new product that's being put out called PUR powder. It's marketed more towards once the families get the dirty water, say they don't have an innovation like the other two, but they're still trying to drink the clean water, they can buy this at anywhere in town that they're selling goods. It's very cheap, can be produced in bulk. But it is new, and Rob and I wanted to test it out on a nearby water source. So, good.
Rob and I are here at to test out PUR powder. It's a calcium hypochlorite mix, which kills a lot of the bacteria, and it also has an iron sulfate compound in it, which will bind to a lot of the bigger particles and help kind of filter them out. So we're going to test that here today. This water is pretty much drinkable anyway, just look at it. So we made a mark, and this is about 10 liters right now, and we're going to test it out. stirred for 5 minutes, and then we let the water sit for 5 minutes. And this is what it looks like at this point. You can see the iron compound kind of binded to a lot of the smaller particles. It's sitting at the bottom of the container, and that's what they call flop. Alright, so to get our cup of water, I'm going to fill this bottle up with the mixture that is not filtered yet, and we're going to put it through the cloth filtering into this cup and wait a little bit and drink it. I'd say that's an improvement. Alright, so we let the water sit for 20 minutes, and you can kind of see how clear it is right there. Looks good to me. Less empty lake water. Coming to you crops near you.
Alright, wait. Alright, so obviously Steve's still here, so he didn't get sick, so it certainly works. But ways you can get involved right now, I mean, we looked for a lot of websites for ways that we could get involved. CharityWater.org was definitely one of the ones that we felt was the most promising. There's actually, you can donate money directly on the site in lots of different forms. I'm sure they take cash and a lot of stuff. I mean, I wouldn't but they do a lot of great things. Actually, the first video you saw in the beginning of the movie, they actually put a well there that same week for that hospital, and that hospital now serves much more than 30,000 people, and they all have clean drinking water. So it does a great job, and thanks a lot for listening.
All right, our last presentation, and thank you again for your patience. I know you have a very busy schedule. We're going to end on water, and we're going to bring the discussion and the importance of it back to the United States and show that these issues are not always out there where it seems so distant. They're literally, as you'll see by Chad and Jack's presentation, they're right in our backyard. So Jack and Chad, bring us home.
Alright, so tonight we've talked about Africa, we've talked about Cuba, Thailand, India. Let's bring it back home now. Over spring break, Jack and I traveled to Charleston, Virginia, where I'm from, to Roanoke, Virginia, where Jack's from, and we collected our original footage for our very short documentary, but hopefully you all will enjoy it.
First off, we kind of talked about the last presentation, but let's talk about ours too. Given the choice, which water would you prefer to drink? This water, we took the coal that is found in Power Our University, crushed it up, we burned it, and we put it in this glass. Given the choice, which would you rather drink? I think it's pretty clear that you're going to pick the clear one. But the reality is, for a lot of people living in Central Appalachia, they don't have the choice. And what we kind of came to wrestle with is, if they're forced to drink this water, why should we get them on drinking on the drink? So with that, I'd like to show you a short documentary that we filmed.
electrical and heating needs. That is more weight than if every single human being on the planet stood on a scale at the same time. That is 1 year's usage, and that was 5 years ago.
This is mountaintop removal. This is where most of the coal comes from. Mountaintop removal is a cheaper, faster, and more deadly way to mine coal. But how does it work? You begin with a mountain. You blast off the top with explosives. In fact, 3 million pounds are used against West Virginia mountains daily. And then you harvest in the coal seams. Just like when you dig a hole in your backyard, the earth naturally expands once soil and rock are removed, so that not all of this removed soil will fit back in. This leaves mining engineers little choice other than to dump the excess into the valleys below, where streams and creeks establish watersheds, creating what are called valley fills. Hard metals and chemicals are found naturally in rock all the time. As long as the rocks remain inside the mountain, we are safe from their effects. However, when we blast them off the mountain, all these toxins are exposed. If placed in a water source, such as these small rivers and streams, the water source will become contaminated with the toxins, putting all those who drink it at risk. Thus, mountaintop removal presents one of the most serious public health concerns to the region and soon the entire southeastern United States. As drinking water becomes poisoned, residents have literally begun to fight for their lives.
As frightening and disturbing as this may be, the reality is that 54% of this nation's energy comes from coal. Coal runs everything. It heats the water that we clean ourselves with. It allows us to communicate with our friends and family. It runs the internet and computer systems. It lights our homes. And it provides over half the energy we need to save lives every day. And finally, this university would not function without coal. Imagine all of this cut by half. There's no way around it. We need coal. The question that we must ask ourselves has now become, what is the cost of being coal dependent in this nation, especially in regards to public health?
This is important to you because coal affects the way you live your life every day. We need to be aware of where this energy comes from, the controversy surrounding it, and how it affects our friends and neighbors' health and livelihood. What is in coal country's water today will inevitably be in yours tomorrow.
The main goal for the industry is to maximize profit. They don't care about people who has to live around these areas, or what happens to the water, or what happens to the air, or what happens to the rains.
Our travels took us through the twisting hollers of Cabin Creek, West Virginia, that bear the scars of coal mining, from the dilapidated dwellings to the monstrous coal trucks. This was textbook Appalachia. As we left the paved road and headed for the summit, vast moonscapes, blasted earth, and sculpted quarries placed the rolling peaks that typically define this land. We soon arrived at Kafer Mountain, an active surface mining site that spanned as far as the eye could see.
Just 2 mountains over from the Upper Big Branch Creek mining disaster that recently killed 29 miners, where we stood was technically considered a reclaimed mine site. In just shy of 2 years of active surface mining, Kaferd Mountain Summit had been stripped over 500 feet.
One of our leaders, Chuck Nelson, was a former coal miner of 30-plus years with Massey Energy. He's now an adamant activist against mountaintop removal. He's watched his community he grew up in been devastated by poor water quality, employment exodus, and mounting health crises.
My name's Chuck Nelson. I grew up on Coal River, spent my entire life there. I worked 30 years. I'm a retired underground miner, and now I'm a volunteer for the Ohio Valley Environmental Coalition. I'm a volunteer community organizer.
He explained to us how heavy metals affect water quality. When he turns on his faucet, selenium, arsenic, lead, and other toxins make his drinking water unsafe. He explained the problem he's witnessing and shared some personal stories of the devastating health effects.
These people that are dying here because of what the coal company is doing to our watersheds. wasn't until we got the community together and we started passing around a notebook that says, if you have your family has any illness, write it down, and so they'd write it down. And we said, well, there's only one thing that connects all y'all, is that you drink well, you're all on well water. That's where you get your drinking water. That's your drinking source, that's your water source, that's your life. Y'all are living on well water. So when we started testing the water, we've been finding a lot of heavy metals in it, because the heavy metals will be in the water before the water turns flat. So by that time, a lot of people's already contaminated. At that time, we didn't realize it was the water contamination. And I sat and I watched him get worse and worse until he died. And then come to find out, this was like in the early 90s. And maybe 3 years ago, here I am in the same community, finding out that there's a whole lot of brain tumors in these small communities. 80% of the people have gallbladder tumors. He showed this boy, 22 years old, named Jocelyn. They was interviewing him in the hospital. He's laying there in bed. He don't have no hair because he's had so much chemo. The only thing he did was drink a gallon of Kool-Aid made with well water every day. And before they could air that and get it, to the news stations and air it, put it on TV, that boy died. You see people just dying off. And at young age, there was a little kid in print, wasn't 3 years old, had crowns. His whole mouth was full of crowns where the heavy metals in the water was so corrosive that it eat the enamel off his teeth. And it was on the front page of the New York Times. They've done the test. They know what the results are. The same thing that's in people's drinking water is the same contents of the slurry. What kind of life are they going to have when they grow up on this river? It's not just an isolated issue. It's not just Cold River. It's 4 states here we're talking about. And it concerns a lot of people.
Chuck had mentioned the coal slurry, which is the forgotten side effect of the politically popular clean coal movement. Clean coal is essentially coal that has been washed with detergents and chemicals so that it burns cleaner. But all of this dirty coal residue has to go someplace. The slurry is either placed in gigantic slurry ponds or injected into old underground mines. Either way, there is no way to make sure that these highly toxic chemicals don't infiltrate the groundwater. One such slurry pond is located directly behind Marsh Fork Elementary School. This slurry pond holds an estimated 2.8 billion gallons of toxic coal waste. That is enough sludge to fill over 4,240 Olympic-sized swimming pools. There are many of these across Appalachia. Imagine going to school as a child, knowing full well that slurry dams have failed in the past, as was the case with the Buffalo Creek disaster of 1972, which caused environmental devastation 40 times greater than the infamous Exxon Valdez oil spill.
Julian Martin, a retired chemical engineer, was kind enough to share his knowledge of stream quality and his love for the region.
The mountains that I love, that I lived in, played in, hunted in, driven by for years and years and years, that are disappearing.
He spoke of a study that found a correlation between stream contamination and deformities in fish, such as both eyes on the same side of the head and curved spines. He implies that if this is what water is doing to the fish, imagine what harm it is causing humans. Julian then directed us to a study by Dr. Michael Hendricks of West Virginia University, showing that coal-producing counties have higher incidences of major health conditions, including heart and lung disease, as opposed to non-coal-producing counties. Finally, Julian left us with these words.
Win, lose, or draw, I do not want the coal companies having the last say on this. Hopefully, to the very end of my life, hopefully, I will point out that they're lying, and that their lying is destroying West Virginia. and it's destroying everything that I hold dear, and it's destroying the future.
We learned a lot with all the people we talked to and the things we saw. From blasting mountains to enormous power plants to people desperate to save their community. But the most shocking part of all of this
is that all of this is happening in the United States, the most powerful and wealthiest country the world has ever seen. The fact that we have people who cannot drink their water is not only unethical, it's a disgrace.
Thank you all very much for coming. Normally we have a sort of a closure on this and a Q&A, but there's literally another group that has this room reserved at 9 o'clock. And they are nose pressed to the window. So we're going to adjourn to the outside chamber. There's plenty of unhealthy cookies and soda there for you. So please indulge. I want to just real quick thanks to Kay McDonald and Andy Gurka, who are the visionaries and the people who make this program run. So thank you all very much. Thank you all.